Well, I think it started.
Yeah, I don't think that's clarification.
Tyler's now, yeah, Tyler's, I can hear Tyler's now finished. Actually, we'll just probably wait for Tyler, just hopefully she'll be in next.
Got such a good name for mandibular. It may be one of my favorite name joints.
I mean, I loved it. I love it now. After I've done that course, it's like I'm buzzing for the temporomandibular joint.
So I have TMJ.
Yeah, don't
Sounds so exotic.
That's, you know, that's the first person, that the woman who presented it, it's the first thing she said. Do not say I've got a TMJ. You do not. Yes, everyone's got a TMJ. You have TMD.
Yeah.
Yeah.
Right terminology. She was like proper, like.
Hold myself back when the patient said.
Yeah, I've got TMJ. No, yeah, you have. You got two of them.
No shit.
I'm gonna leave you to it.
Okay.
Ashley,
Bye. See you.
Just onto the toilet machine.
It's not one made.
Right. Hopefully we can get
Next
through.
up.
No.
Someone else. Oh yeah, to say Shannon's joining us, isn't she? Hi, Shannon.
Ashley, read the thing I started.
Oh,
I have. It's really, really good.
Yeah.
I think we need to compress it, but it's really good.
Yeah, edit loss.
Right, we're all here.
yes.
Right. Okay, so basically we've got 3 sessions on this. So today is anatomy and biomechanics. So we're going to have there is going to be quite a lot of information, but there's also going to be a little bit of play around. We're going to have a lot of palpate the muscles of mastication. We're going to have a feel around your TMJs as well.
Muscles of mastication.
Yeah, what a name, eh? They're great, aren't they?
You just did it to say that, didn't you, Stu?
Yeah, it's exciting, isn't it, saying mastication. Right, okay, let's get started. Right, so we're talking about, so what we're going to do today, we're going to look at the anatomy of the TMJ. So we're going to look at the bones, the disc, the capsule, the ligaments and the muscles. And then we're going to look at the biomechanics of how it all moves. So we've got depression, elevation, lateral protrusion, protraction and retraction. So we're going to go through all that. Let me just move this up the way. If I get, that's better for everyone, isn't it? In fact, actually,
Somebody else that sees that.
should we go there? Yeah.
Have that leg weight at the top.
How can you change it then? Right.
How are we doing? You all right?
Yeah, I'm just trying to get, because it just gets in the, like, where everyone, I can see everyone, it gets in the way of the screen, if not for this lot, for these lots to see everything.
If you go to the top and there's like a 6 icon, if you press that and scoop it to the top, you can pretty much lift everyone into a 4, and then you can still see the screen.
And you can change the, yeah, got it. Oh no.
That's a shaft.
Hold on, go that way, then go across. Oh, there we go. Hold
Hold
on, one more. We'll get there eventually. Right, there we go, that's better. So everyone can see the screen then. And now I can see you lot as well. Right, so to start with, we're going to look at, we look at the anatomy. So we've got, obviously it's made up of the mandible and the temporal bone. So basically, we've got different parts. So look at it on the left-hand side of your screen. So you can see we've got we're seeing mainly the mandible. You can see at the top, you've got the joint there. Okay, so you've got the lateral, see the lateral pterygoid muscle? Okay, so yes, you can see me pointing the mouse, yeah? Okay, so you've got the lateral pterygoid. So the lateral pterygoid muscle is actually made up of 2 fibers. So we have a superior and an inferior, and they do different things. Okay, so it's really important to know. And one of them inserts into the actual disc. So the superior lateral pterygoid muscle is actually connected to the disc. So it has an important role to play. If we look onto the right-hand side, it's like this is looking at the joint itself. So you can see see where I'm taking the mouse across here. So that's the actual disc, okay? And the disc is made up of 3 different areas, 3 different regions. So we have an intermediate, a posterior, and an anterior. And things change when we go into different movement patterns, which we'll explain a bit later. Okay, so the articular surfaces is like 2 bones, but it's also over 3 surfaces. So if you look on the right here, we have, so we've got the mandibular head, okay, which is in blue. We have the inferior cavity here. We have the disc, which is green, and we have a superior cavity. So the disc basically gives us 2 cavities in the TMJ, okay? So we have an anterior cavity, sorry, a superior cavity and an inferior cavity. And then at the top, we have the mandibular fossa, which is where the joint surface is there. And we also have this articular tubercle. Okay. So when we move and open our mouth, the mandibular head starts off around in this sort of mandibular fossa area, but it basically protrudes, it rotates and protrudes forwards onto this articular tubercle. So that's why we have 3 surfaces. Okay. So we have 2 surfaces on the the temporal bone, and we have 1 surface with the mandibular head. So it's the most complex and most used joint in the body. Anybody have any idea how often we use this joint daily? Give me a rough figure. How often do you think we use this joint?
Like minutes, yeah.
Or how many times a day do you use it? As in a number. Give me a number.
500,000.
So some people use this a lot more than others, I think.
Yeah.
So on average, is about 5,000 times a day.
Possibly more than that.
Yeah. Those are rookie numbers. Need to bump those up.
Yeah. So you can see that this joint is it's used a lot, and it needs a very good architecture, and this disc plays a major role in it. It's a very unique joint. It's a Siamese joint, so we have the same on both sides, obviously, and it's made up of fibroid cartilage and disc, because that fibroid cartilage and disc are very important. You think the amount of load that goes through this joint and the force of all the muscles, because the masseter is our strongest muscle in the body. So we're basically putting a lot of force on this joint, and that's where that disc is really important, which we'll explain later. Okay, so we have the temporal and mandible bones. We have the articular disc, which is the grey. Okay, we have the retrodiscal tissue, which sits at the back. Okay, so on here, it sits around. This isn't a very good picture for that retrodiscal tissue. If we go back to this one, see all this yellow blobs bit here, that's the retrodiscal tissue here. Okay, so this is an extenuation of the disc with like a ligament, and this is the superior ligament as well. So these basically hold this retrodiscal tissue, which is really made up of fat, sort of that artery, that sort of thing. So it's not, it's made of those different things. So we have ligaments as well. We've got 3-4 main ligaments that we have in this area, which we'll go through. We've got the muscles of mastication, which we're going to go through and palpate today. We do have that neurovascular supply, but I've not actually added this into the presentation because it just got a lot, there was far too much otherwise. So I'm going to go through this today. So looking at the mandible first, we have the mandibular condyle, which is the head at the top here. So we can actually palpate that ourselves. So if we go onto our zygomatic arch, drop down, you'll feel a little dip. Okay. Now, if you just then palpate around that area, and if you just open your mouth slightly, you'll feel something move. Okay. So that's basically you're palpating around that head. Okay.
It pops out that one.
Yeah. So what will happen is, which we'll go through anyway later, but what happens is as you open your mouth, you get like an anterior rotation, and then you get an anterior translation. So you get 2 movements. I don't know if you can feel that. If you go either side, so as you just keep your mouth shut to begin with. Now, as you open your mouth, you should feel like a slight anterior rotation forwards, and then you'll get an anterior translation of that head. Okay. So that's that head moving from that fossa onto that articular area, which we talked about, those 2 different areas on the temporal bone. So we have a neck. Okay, here we have the ramus, which is the body on this part here, we have the angle of the mandible at the bottom, which is where our on the inside of the mandible, we have the medial pterygoid attaching. And then we have the body, which is at the front, mandibular notch, this little gap here, this little hole, which is where we can stick a nice needle into that lateral pterygoid, which is, I do that loads, to be fair. I love sticking a 40 mil in there, it's great.
Works out.
Yeah, it's really good. Because otherwise you won't get to the actual muscle. It's very deep inside. So a 25 mil needle in there is not going to do anything.
What is it, 14 then?
So a 40 mil, yeah. So 40 is quite big. Yeah. It goes in quite a way, to be fair. And then we've got the coronoid process. So coronoid process is where one of the other muscles of mastication inserts into. Does anyone know which one it is?
What's that?
Which muscle inserts into the coronoid process?
Coronoid,
Coronoid process, yeah. So that's on the front.
the other medial tail.
Nice. Your temporalis. So your temporalis inserts into that coronoid process. And then we have a lingula, but the lingula is on the inside. So if we turn that, because that's obviously looking on the outside of the jaw. If we go on the inside of the jaw, you have a lingula, which you can see on this picture here, look, on the inside. Okay. So there's loads of little foramens as well where nerves run through. So the temporal bone, okay, so you can see across here. So you have the mandibular fossa, which is this area here. See where my mouse is going up and down? That's a depression in the temporal bone. We have the articular tubercle, which is where the head of the mandible will move into. And we have an articular eminence, which sits between the two. Okay. So that's where the mandible slides over during that movement. So the mandible moves, see where the mandible is here? It moves forwards and sorry, it rotates down and translates forward in that sort of angle of my cursor. Okay. So also, so the articular disc, okay, like we said, it divides the TMJ into two cavities. So two synovial cavities. We have a superior and inferior. So they're both lined by a synovial membrane. So that disc is made of it's like a dense fibrocartilage, collagen and elastin. So it can move really well. It basically can change the structure of that disc. So it has areas of avascular, okay? So it has an avascular area, which has no innervation, and that's in the central portion. So in this central portion here, so there's absolutely nothing, you're not getting any feedback at all from that central part, whereas the anterior and the posterior part are vascularized and innervated.
So why some people's, when they have like disc reduction, some people it's painful for, some people it's not. Is it more to do with where along the disc it's being
Possibly, yeah.
recruited from, or I thought there were like variations in some people's,
What the size of the discs, or?
no, like where it's being, where the disc was being pissed off.
Yeah, because the disc could be, so at the moment so the disc can be put into different positions.
Yeah.
Yeah. So it might be so we'll do that in the next part. So that's the next sort of area, but the disc can be in the wrong position initially. And it's sort of like the disc is dislocated, basically. It's like the disc is being dislocated and it's in the wrong position to begin with.
Yeah, it was more, is that why, because of how, where it's vascularized along some areas, and some not, is that why?
So you might have
It's painful for some people and not others.
possibly, yeah, because you've got different areas of innervation. Yeah. So basically, the middle part of that disc is not innervated at all, but the two ends are innervated and vascularized. Okay. So the functions of that disc is to absorb shock and load distribution. So it reduces friction between the surfaces, and it allows that, what we talked about, that complex. It's a very complex movement. This TMJ is a very complex movement. There's no other joint in the body that moves like this. Okay. So if you look on this picture here, so you can see there's the head of the mandible. Okay. That's the disc here. Okay. And then you can see that it moves forwards and then onto this area here. Okay. So
Awesome.
it's a very sort of like, if you look at it, so that picture there sort of corresponds to this picture here. Okay. So you can see, look here, and also as well, when we look at those lateral pterygoid muscles, so you have a superior part. So that superior part is actually part of the disc. Look, so you can see it, it actually attaches to that disc. The inferior does not. Okay, so you have an inferior lateral pterygoid and then a superior lateral pterygoid. So the superior part attaches to the disc. Okay, yeah, right. And again, this is another picture. So you can see this is the lateral pterygoid, superior part, inferior part. There's the condyle of the mandibular bone. There's the disc. The blue is the disc. Superior cavity there, like sort of green, sort of, and then there's the disc. There's the what do I call it? I forgot what I called it now. That disc stuff in the back. I forgot what it's called.
Retrodiscal tissue, I think you called
That's
it.
it. Retrodiscal tissue. That's the one. Oh, it's bloody hell, it's a bit of a mouthful, isn't it? Okay. And then you can see just slightly that there's the inferior part of the joint as well. Okay, so the different compartments, superior compartment, inferior compartment. So the disc just splits those two. Okay, so that articular disc, so attachments. So again, like we said, anteriorly we have the superior lateral pterygoid attaching into it. Excuse me, and then posterior have that retrodiscal tissue. So the superior part of the retrodiscal tissue can be folded and lengthened, whereas the inferior is non-elastic. So we've got two parts to that retrodiscal tissue. Okay, so the lower part can move, and and you'll see when we do. Sorry, the top part can move, and you'll see when I show you a video of how the disc moves, why that one part can actually move. It has to basically change its shape, and the other part remains the same during movement. So it's a very clever joint. So then between those two layers, or between those two areas, we have that fat synovial fluid, nerves and blood vessels that sit in that retrodiscal tissue.
Is the retrodiscal tissue innervated?
Yes. Yeah. It's only the middle part of the disc which is not innervated. Everything else is.
Well, because it's just not the bit that needs to be.
No, it doesn't need to be. No, because that part is obviously it's just because that stays in contact between the condyle and the temporal bone. Yeah. Whereas the other parts move around. So what we have is, like we said as well, with that articular disc, we've got three zones. So we have an anterior and a posterior band. They fill the space of the joint, and then the intermediate part, which is the thinnest, remains in contact with the condyle, like I just said. Okay, so if you look on this picture, it sort of shows a bit more with those. Like the pink is the anterior portion, green is the middle, and the red is the posterior portion. Sorry, wrong way around. Wrong way around. Red is the anterior because the muscles are coming here. Yeah. So that's looking from the side of like someone if they're right-sided, okay, on their right side, looking forward that way. So superior head of lateral pterygoid into the front part of the anterior disc. Intermediate part here doesn't really change shape, stays in contact with this articular eminence and around that fossa. And then you've got the posterior part as well. Then you've got the two blue regions, what we talked about, those two, the superior and the inferior part of that retrodiscal, what we call lamina. And then we've got the joint capsule that sits at the back, look.
It's by laminate zone, two of them.
Yeah. Okay. So these are the ligaments. So we've got basically lateral ligament, sphenomandibular ligament, and the stylomandibular ligament. If you look on the pictures on this first one here, so the lateral ligament sits just above. So this is the capsule over the TMJ, the sort of like the yellowy, orangey sort of part. And then the lateral ligament just sits above the two of those. So it comes from that zygomatic arch and then goes on to the neck of the mandible. Okay. We have this purple is the sphenomandibular ligament. So that basically that limits the anterior. So they all sort of limit anterior TMJ movement. So they're stopping the TMJ from moving forward. Okay. So origin of that is spine of the sphenoid bone. Okay, and then insertion into the lingual of the mandible. So that's looking. So this picture here is looking on the inside. This is looking on the outside of the mandible. This is looking on the inside of the mandible. Okay, so you can see that one holds in that position there. There's the joint capsule there. Okay, and then we have the stylomandibular ligament, which is this red ligament here. So that basically comes from the styloid process off the temporal bone and then onto the posterior angle of the mandible. So it sits on the back of that mandible. Okay. So the capsule is an outer dense fibrous membrane and it has an inner synovial membrane. Surrounds the entire TMJ. So it's tight inferiorly but loose anteriorly because it has a lot of movement to do coming forwards. Okay. So this is now looking at a left-sided TMJ, okay? So you can see, so this basically, where the green is here, that comes forward, so it rotates and comes forward. So basically, like you say, it's highly innovative, but obviously part art. Function is provide stability, proprioception, and it also encloses the synovial fluid as well. It borders of the mandibular fossa, okay, across here, and encloses that articular tubercle which sits at the front here. Okay, and then this is the eminence that sits between the two. And then the insertion is on the neck of the mandible, basically down into here. Okay, so what's the requirements of the TMJ? So we need coordination to chew, we need that dynamic ability to produce speech, we have endurance as well, because we do a lot of talking. Don't know why they put chewing gum, to be fair. But basically, we need endurance, and it needs to be strong enough as well to bite through like hard foods. So it's a very important joint. Right. Are you still awake? Good. Right. So now we're going to go through these muscles of mastication. Okay. So we're going to basically start doing a little bit of palpation of these muscles. So all of these 4 muscles insert into the mandible. Okay. So if we go into each one, so so this is looking at the insertions, okay, on the mandible. So that's the top one is looking on the inside of the jaw, okay, and the one on the bottom one is looking on the outside of the jaw. So you can see, look, lateral pterygoid basically inserts at the top and the neck of the mandible. Temporalis comes over that coronoid process. Medial pterygoid on the sort of like the angle of the mandible. These are, and obviously we've got other muscles which we're not going to really talk about today, but we've got other muscles, your hyoid-like muscles and your digastric, which are responsible for opening the mouth. So there's only one of these, out of the muscles of mastication, only one of these opens the mouth. Do you know which one?
One of them opens the mouth.
Yeah, there's only one of these that opens the mouth. Any ideas?
Lateral.
So lateral pterygoid. Lateral pterygoid. Because basically lateral pterygoid is the initiation of opening the mouth. Okay. Whereas the other 3 are basically are closing the mouth. There are muscles of like
chewing,
to close the mouth, chewing and biting, all that sort of stuff.
If they get short, it's going to close, doesn't it?
Right. So masseter, strongest muscle in the body, is rectangular. So the function. Well, why do you think it's the strongest? It's got a lot of things to do.
You're never strong enough to bite off your own finger.
Yeah, you probably are. Yeah. Yeah.
Like your brain will stop
Yeah.
there, but you could bite off
Yeah.
your own.
So that muscle is like we have to produce a lot of force, don't we? At when we bite and you know when we eat and things. Okay. So function is to elevate and protrude the mandible. Okay, so it lifts so it closes, basically when we talk about elevation, we're talking about closing the mouth. Okay, so it also protrudes.
So now it's recorded.
Yeah. Yeah, it's been recorded. Yeah. So we have a superficial and a deep portion. So the superficial head, basic origin is on the anterior 2/3 of the inferior border of the zygomatic arch. Okay. So this part here. Okay. So you can see on that zygomatic arch, and then it comes down into that lateral surface of the ramus, and because the ramus is this part here, and then it comes onto the angle of the mandible as well. Okay, and then the deep portion, which is a bit further back, that sits on the posterior third on the inferior border of the zygomatic arch, and that inserts into the lateral surface of the ramus, so a little bit higher up. Okay. So temporalis, big, large, fan-shaped. So we have two. This literally has two functions as well. So we do have anterior fibers and we do have posterior fibers, and they are slightly, even it looks on here that the orientation of their fibers are slightly different. So the anterior part, the fibers are vertical going down, and the posterior, they're more horizontal or oblique. Okay, so they do different actions. So we have parts of the temporalis. Okay, so the anterior fibers will elevate and the posterior fibers will elevate, and they'll also do retraction as well. So if you think of the angle of this, of them coming across here, as they, because see where they insert right onto that coronoid process here. So if you imagine those shortening here, they're going to pull that jaw backwards into retraction. Okay, and then these fibers here at the front are going to basically lift and close the mouth. Okay. So lateral pterygoid. Origin comes from the greater wing of the sphenoid bone. So the sphenoid bone is like a fan-shaped bone that sits in our skull. Okay. I did have a picture of it, but I'm not sure we need to actually use it. So basically, the superior, like I said, goes into the disc, and the inferior goes onto the on the process. Okay, onto that basically onto the neck of the mandible. Okay, so some pictures show that the superior is smaller, and some pictures show that they're the same size. So it varies. I don't know what the actual size of them are, but some like on this picture, it looks like the inferior muscle is a lot bigger than the superior muscle. But on other pictures, it shows them being exactly the same size. So I don't know what the actual answer is, because even on this picture at the top, it does look as though the top one is a little bit smaller. So basically, the functions of lateral pterygoid. So as when they work bilaterally, they assist with protrusion, and they start depression of the and they start depression of the mandible. So basically, depression of the mandible just means opening of the mandible. So unilateral, they move this mandible side to side. So that's that laterotrusion, as they call it. Okay. So when they work unilaterally, they work so we can get side to side movement by working the lateral pterygoid. So it's always the work. So when we talk about a working side and a non-working side. So when we go, say you want to move your jaw to the right, so it's the right pterygoid that is working, lateral pterygoid that is working to the right. Okay, that's classed as the working side. So medial pterygoid. So origin is the maxillary tuberosity, and then the insertion. So we have we've got superficial and deep, and that's looking from the inside. Okay, so underneath. So it's like we're looking underneath the jaw. So that's the front of the teeth. This is more. So this is underneath the jaw. Okay, so you can see. So this is more the superficial, and then the other one behind it is the deep. Okay, and that muscle there is the
Pterygoid.
Lateral pterygoid.
Area.
The eyes. I said, what muscle? Okay, and then what's this muscle here on the side then?
Masseter.
Masseter, yeah. Okay. All right. So So summary of the movements then. So we've got elevation, okay, which is closing of the mouth, okay. So we're using temporalis, we're using masseter and medial pterygoid. Depression, which is opening of the mouth. We use these other muscles, which is digastric, geniohyoid, mylohyoid, and then initiated by lateral pterygoid.
The press would be closed.
Yeah, so you depress something. Depression is closing something, though, isn't it?
Questions like sadly, you think close your eye. I mean, close your mouth.
Well, I like your theory, but it don't work, Tyler.
Thanks.
I think elevation is right.
And then we think so with depression, yeah. So protrusion.
Very
So
down.
you're coming forward. We've got the lateral pterygoid, medial pterygoid, and the superficial masseter. And then for retraction, we use posterior fibers of temporalis, which you talked about earlier. We use the deep part of masseter, the geniohyoid, and the digastric. And then for lateral deviation or laterotrusion, as they call it as well, we have the lateral and medial pterygoid working on that side. So what we're going to do, in fact, I'm going to show you this little.
Lateral deviation's a good night out.
So can you see
So everything
Mo?
here,
Can you see Mo?
appear, and with a click and collect, we've been ready.
It's not the norm.
So this just shows like how it moves. There's the disc. So the disc moves. So that's only the middle part of the disc. That's not all of the disc. So then the muscles come in. There's lateral pterygoid here. So that's attached there and pulls it forward. Yeah. So you can see what like it's a really like it's a great jump, isn't it? A great jump, a great joint. Freaking hell. Yeah. So these are showing some of the issues that can happen. We've got 20 minutes. We've got plenty of time. Right, let's get rid of that. Right, how do I get back to the other one? Yeah, see, hold on.
Yeah, Dreamliner.
Hold on. I'm just being dumb again. There we go. See it now? Right, okay. Have I shared? Can you see that?
Mm.
Yeah? Hold on. I want it to.
We haven't finally seen it, but it looks like timing behind us.
Yeah, no, that's fine, isn't it? I think.
Yeah.
Yeah, that's all right. Okay. Right. This before we go into the biomechanics, we're just going to palpate those muscles. Okay. Right. Who wants to be my volunteer first? Anyone got any TMJ issues? Or think they've got any TMJ issues?
Well,
Right, let me stop share.
might do after this.
Because I really never opening.
Ellie's
My jaw used to lock.
9 to 8.
I'm sure you
You got-
You used to click loads, one day it clicked and locked and I can't open it since. Why not? Like, notice it.
Are you happy for me to stick my fingers in your mouth?
This helped my thing.
Right.
Probably not. It's not even gonna fall into your.
So we can do 2 of these muscles extra orally, and we'll do 2 of these muscles intra-orally.
Did it. Go to the every time.
Reckon.
So if we just do temporalis first, okay? Can you guys see that okay? Okay, so basically temporalis is in that temporal fossa, okay? So we can go basically from the orbit of the eye, from the outside of the orbit of the eye, if we just drop in, now we're onto the front part of temporalis, So if you just, if you just squeeze your teeth together or bite down, okay, so I can feel Ellie's anterior portion of her temporalis, okay? Now, what I'm gonna do then is gonna come up, so you can work all the way back round, it's a big area, okay? So you can come back into the posterior part, and then if you basically, do you remember what the posterior part did? Did it protract or retract?
Retract. So
Retract.
we'll get my head around, like, why do we even do that? The only time I feel like I do that is if I like yawn or something. Like, it's just like, would you retract your jaw?
Get it back in. Because it comes forward, so it has to go backwards to go back in the.
Yeah, because you might be protracted. To get it back to neutral, you need to get it retracted.
Yeah, okay, that makes sense. Yeah, sure.
From back, yeah. So as you go, you can feel that muscle switching on. Okay, so nice, easy one to feel. Temporalis. Feel the difference between the anterior. So get them to bite. You can feel the anterior portion, and then get them to retract, and you'll feel the posterior fibers working. Okay.
You can feel the posterior fibers when you like close your mouth from being open.
I mean, you want to practice on each other, it's fine. Okay, and then for masseter, we come down to the angle of the mandible. Okay, and if you can think about that zygomatic arch, so if we go back to here, we can come across the front here of a zygomatic arch.
So
The basically the muscle comes from, so the deep portion comes from the first 2/3, and the superficial comes from the first 2/3. And if you bite down again for me, yes, so you can feel a really good contraction of that muscle pushing back up against you. Impressive masseter, or as John Hobbs says, masseter.
Excited, Kelly.
I couldn't believe it when I was doing the thought, where the hell's masseter? Never heard of it.
I called it Masita. No,
yeah, Kelly was like,
Masseter.
Masita.
Yeah, you're a John Hobbs lover, though, aren't you? Hey, Kelly.
we got it wrong. Good old John.
When you respect the anatomy.
Does she call it Masita? Do you call it Masita? Do you?
Yeah.
Really?
I think it sounds much better, don't it?
There's a thing
Masseter.
now. We're gonna make it a back and body thing.
Masita.
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 I can't. Yeah, I can't change my habit. I won't be able to do that.
You're not a proper John Hobbs fan. You're not a proper John Hobbs fan.
Okay. Right. So now, I don't know if you are we on full screen to you guys? Yeah. Okay. Right. I don't know if someone wants
Eat her.
Can I ask a question?
Yeah.
If someone's got a jaw that's like, is it called an underbite when it sits kind of with their bottom jaw sitting forward? What does their joint look like? Is their lateral pterygoid on tension and stuff all of the time? Or do they just have a slightly
Their
different
lateral
joint?
pterygoid is going to be
Like elongated all of the time?
so it's going to sit forward, isn't it? Their lateral pterygoid is going to be elongated.
Yeah, so their joint is it looks elongated. It's not just a different joint, or like, do you know what I mean? It doesn't look different. It just is elongated.
That is a good question.
Sorry, I was just sat there thinking, if that's what it does, if people that have a slightly
You've killed Stu with that question, Shannon.
He's gone.
He's like, screw this.
No, that was Jazzy mucking around. No, the camera goes a bit like weird in here. Yeah, so if they've got a protruded, so they're going to have their lower jaw is going to be protruded forward. Okay, so they're going to be putting strain on that lateral pterygoid. The lateral pterygoid is going to be lengthened.
Be lengthened. Okay, so just checking.
Yeah.
Thanks.
Right. So if we go to lateral pterygoid first, you okay? Yeah. What it might be, if you pop around that way, I'm going to go from this way so they can see. So if you turn your head towards the camera, right. So open your mouth for me. So basically, you need to. So for lateral pterygoid, we're going to go to the top.
Look at, they're so white, like your skin is like glowing.
I'm not the same colour as this.
Glowing.
So for lateral pterygoid, we're going to go towards the top part of the molars, and we're going to go to the back end. Okay, so if you just open your mouth for me, rotate
You
that.
won't ask questions when you're doing this to yourself.
So we're going to go onto the outside of the molars. Okay, so if you go here, I'm going to get my finger and I'm going to protrude all the way up round. So I'm hit the back molar, and then can you open your mouth a bit more? Right. So as I go past that back molar, I am now going to sit onto there. Right. Can you just make so you can just bite my finger just gently. There we go. So now I can feel that muscle.
That was cute.
Hard to see.
No, so they're all laughing and Stuart.
Well, I know they're laughing.
Oh.
I'm just ignoring it.
Sorry, we are fully watching.
Yeah. It's okay, I'll take it out. It's so the muscle is rock solid. It is not a soft structure when you get your finger on it. Okay. So all you can do as well is you can basically get your finger, and what you might feel is that you get referral pattern into different parts. You might get it into the tooth, into the side of the head, but you're basically going to find the back. So if you use the back, so if you put your finger in your mouth in the corner, so if you use the back, so the back of your nail, yeah, and as you go past your last molar, literally go up,
My
and
finger.
then you'll feel
Why that way round?
the firm object.
How come you use the back of your finger?
That's it. Yeah.
I was always
So
trying
go
to go that way.
go to your opposite. So
Right hand then, left side.
yeah. So go opposite side.
You
Yeah.
know, finger.
How come you use the back of your finger?
Well, you can use either.
Because I normally do like a pincer.
So I'd always do it.
I get my thumb in.
Which way around do I go?
You stick your thumb up there.
Yeah.
Okay.
What?
No, actually, maybe I wouldn't. Hold on. No, I would. No, I would do my index.
He uses
I
fingers.
do it
for control.
like that and pinch.
No.
I wouldn't use thumb. I would use my index.
Oh yeah.
Oh.
Oh yeah. That's better than mine actually. I quite like that. Hold on, let me change his gloves because my fingers are like that. Right.
Oh
Is
yeah.
it straight into yours?
No, they didn't like dirty bus.
What?
I was thinking of doing
I see what you...
Yes. Bloody hell.
I was like, that's
Ignore
something.
that. Scrap that.
What happened?
Right. So for medial pterygoid.
I missed what happened.
It's fine, she's alright. She's alright.
Hey guys, you're alright.
Oh.
Okay.
Got him, I don't leave gems.
Right. And for medial.
Like showing DNA.
And this is recorded, right?
And then for medial pterygoid, we are going to go on the inside. So we went on the outside with the lateral. We're going to go on the inside on the lower part of the jaw. Okay, so if you open your mouth. Okay, so we're going to, it's basically, you're going to go towards the back of the tongue. Okay. So I'm going to basically come in. Yeah.
Like
So if you start, so if you start on the teeth and you work your way to the back of the teeth, just relax. Okay. Relax. The trouble is, you might get a bit of a gag reflex with this one as well. You open a bit. Right, can you bite down? Yeah, Ellie's not a good patient.
What are you trying to do?
Medial
No,
pterygoid.
bad patient. You keep gagging.
Right, that's not. But that glove's out of the way, so I'm not actually putting. So hygienically, I'm a bit better now. So follow your finger.
It was just the first one. I wasn't expecting it to go straight down.
So if you pop your
Oh,
finger
I'm glad this really climaxed towards the end.
on the lower jaw, and then as you get to the back, near his tongue,
Yeah,
and if you bite up, if you bite your finger, you should feel that muscle engaging.
I hope for my tooth.
The last woman that I did an intraoral masseter release with liked it so much, she got a job here.
That's fine.
But it does. It is it's a bit of a gag reflex type of thing. So medial pterygoid sometimes is a bit.
You pulling a prank?
Just make me. Right.
So, can I just check here? So I'm not being a numpty. Are we saying, are you between teeth and cheek? Or are you saying we're going like where because you're saying you
So
get
you're on the
finger.
what you're talking about, what, medial pterygoid?
Yeah, which is then.
Yeah. So you go onto the back tooth, but then you go on the inside,
Yeah, right.
not the outside.
Making
Yeah.
sure.
So it's like you're going where the tongue. It's like you're just moving the tongue slightly to one side.
I think I would have been that.
Because you think where it like if you think about it on the other side of the jaw, it's inserting around this area, but you've got to be on the other, like on the underside. Okay.
Properly grim, isn't it?
Yeah, it's not very nice.
No.
No.
No, it sucks.
Yeah, it's quite difficult to get to, but you can actually, as long as the trouble is you make people gag with it. That's half the problem. Yeah.
There's medial more gummy and lateral is more like on the other side of the teeth.
Other way around. Medial's on the inside of the
Medial's on the inside of the teeth. Lateral's on the outside of the teeth.
So I've just found my lateral.
Yeah.
But I haven't found
But you have to go. So each time you just go past the last molar. Yeah. So for lateral pterygoid, you go up and high and up, and then for medial,
Okay.
down. Right. Anyway, let's share the screen again.
Your little one would do something like that.
Yeah.
my mouth wide now.
She'd be like suck all over
Right.
mommy.
Yeah.
So let's just go quickly through the biomechanics then. So if you look on the left-hand side, this is when we open. So you can see we get a forward. Initially we get an anterior rotation of the mandible head, and then we get an anterior translation as well. Okay, but that's all related to that's the lateral pterygoid muscle which initiates it, and then we've got the suprahyoids which cause the mouth to open as well, and the digastric muscle as well. And then for closing, we use temporalis masseter and medial pterygoid, so you can see the angle of action. So we get the opposite thing, which I'm going to go through with you now. Okay, so this is the mouth opening early phase. This is looking from obviously the side. So you can see what we get is a roll, like an anterior rotation, and then we get a translation as well, because that has got to then move to this part. So this is the early phase. Okay, so this is the first 20-25 millimeters of movement. So the main movement is an anterior rotation first, and then we get a translation after. That's in the early phase. So in the late phase, it's the main movement is the anterior translation, and that all happens. See this black at the top? That's what we call the superior compartment. Okay, and the black at the bottom is the inferior compartment. No. So this is where, so this is the middle disc here. Okay, so the middle disc always sits between the head of the mandible and either the fossa of the temporal bone or that articular area at the front. Okay, so that's where we get, so that's that mouth opening. Okay, so obviously the action of that is gravity. So gravity helps with this as well. Lateral pterygoids and then the infrahyoid muscles. Okay, and then for mouth closing, we just have the opposite. So we have contraction of the 3 remaining muscles of mastication, and then we have the relaxation of the hyoid muscles. So in that early phase, we get a posterior translation first, which is the main movement, and that's in that superior compartment again. And then we get a posterior rotation to end that early phase. And in the late phase, we then get the posterior rotation with the posterior translation. So it just works slightly different. It just works in the opposite. So you're always going to get, in the superior compartment, you're always going to get translation. In the inferior compartment, you're always going to get rotation. Do you know what I mean? Do you understand what I mean by that? Yeah? It's better to show on this picture here. So always, you're going to get in this superior compartment, it's always going to be translation of this disc. and in the bottom bit, you're always going to get rotation of the head. Okay, so the head's going to rotate in the inferior compartment, and the head's going to translate due to the superior compartment. Okay. Right, so protraction and retraction. Okay, so the first phase begins with a slight opening for protraction. So the mouth can't translate if the teeth are together. Okay, so again, we have that anterior rotation, that inferior compartment. And in the second phase, we get the translation plus rotation. And that's through both parts of the lateral pterygoid muscles. Okay. So that's assisted by your masseter and your medial pterygoid. And then for retraction, we get a posterior translation, then rotation. Okay. And that's through the posterior. So again, we talked about that posterior temporalis, and then we have the posterior belly of the digastric as well doing that. And then the second phase, we have that posterior rotation, which is your posterior temporalis as well. And then laterotrusion. So we have, like we said, we have a working side. So the side that the jaw moves towards. So in the side that on the working side, we get rotation on its own axis. So if you're working to the right, you're going to get a rotation on the right-hand side, TMJ. It's like a bit of a pivot point. And that's your deep masseter and your posterior temporalis. And then on the non-working side, you're going to get the medial and anterior rotation, but you're going to be working inferior lateral pterygoid and medial pterygoid on that opposite side. Okay. Right. And that's it.
Woo!
Any questions? Any questions?
Very good. I like my favourite bit was when you asked Ellie to bite your finger.
Right, was what?
The highlight was Ellie biting your finger.
All right.
We do that in other sessions anyway, don't we?
Yeah, that's just normal.
That was
Right,
really
and
good. Thank you, Sue.
And then next time, because it should be in 2 weeks' time, but because I only do the next part of this course on the night before, we're going to delay it for a couple of weeks after that, so I'll get time to actually stick it into a presentation. So that then becomes more of TMD and treatment. Okay.
Hot off the press, Stu. That's wicked.
Yeah, yeah. And then there's another part in January as well, but that's more to do with the eustachian tube. So I don't think we need to worry about that third part, because then we'll do for the next 2 parts, we'll do more treatment techniques and all that sort of stuff as well. So
Stu, if that's right, I'd say don't write that third bit off, because actually, like, you know, when we see people with headaches and tinnitus and migraine, it'd be interesting to see how the jaw impacts tinnitus and some of those things as well. So if you've got any pearls of wisdom that come out of that bit, that'd be.
No,
wicked
what
to
I mean
know.
is I don't, because that's not until January.
Yeah.
So
But if you do if we could get you to do a top up of that on Elevate at some point, that'd be really cool.
Yeah.
Cheers, mate.
Audio.
Wicked.
Thank you.
Thanks, Stu.
Thanks, Stu.
See you later.
What happened?